So we're going to continue our journey through the anatomy of the respiratory system at the trachea. So we are right here. And you'll notice from that previous picture that the trachea is surrounded by these 3/4 rings of hyaline cartilage. And the value of those is that they're flexible, but they also help to keep the airway patent, which means to keep it open so that breathing is really effortless. So if you think about it, how often do you really think about your breathing throughout the day unless you're doing something very strenuous? It is lined with the pseudostratified ciliated columnar epithelium. There's goblet cells in that epithelium, so here, that will secrete mucus to help carry out debris or to capture pathogens or capture dust or particles that are in the air that you don't want to actually swallow. In the deeper layers of the connective tissue, there is this seromucus gland, which will also secrete a lubricating serous, meaning sterile fluid. And that helps to keep the walls of the trachea from sticking to each other, along with, when we get to the alveoli, something called surfactant. Now, the adventitia, let me switch to a different picture. The adventitia here is also called a serosa, S-E-R-O-S-A, in other organs. That is connective tissue that helps to anchor the trachea to the esophagus that's posterior to it, as well as to any of the other organs that sit around the trachea, such as the lungs or the posterior muscles of the body wall, or even the pericardium of the heart. The trachealis muscle only lines the posterior area, about posterior 1/4 or so of the trachea. So if you consider swallowing food through the esophagus, now imagine that you ate something that was kind of big, or maybe you didn't actually chew it enough. If this posterior wall of the trachea was fairly hard hyaline cartilage, like these rings are, it could actually get stuck there, and then you may choke, or you may have food stuck in that passageway that would eventually rot. So the trachealis muscle actually helps to allow the esophagus to expand when it needs to, and it does a little bit of anchoring and helps to move food, just a little bit, helps to move food through the esophagus as well. So once air is moved through the trachea, now the trachea is going to split or bifurcate at this area called the carina, C-A-R-I-N-A. It's a particularly sensitive area. It's one of the last places where you can, or your body can check to see if there's anything in that air that shouldn't be. There is actually a real case, it's not an old wives' tale, of an older gentleman in Boston that aspirated a pea and actually grew a pea plant. So the question is, what side do you think he grew that pea plant in? And I'll give you the answer in just a minute. So the trachea bifurcates into these primary bronchi, the left here, the right here, and notice that the left one has a fairly easy angle. The right one has a very sharp decline. And the reason for that is that the heart sits right here in an area of the left lung called the cardiac notch. Now these bronchi, which is the plural of bronchus, are then going to split into secondary or lobar bronchi, where they will feed the superior and inferior lobes of the left lung, or the superior, middle, and inferior lobes of the right lung. The right lung has 3 lobes because the heart's not there, taking up some space. And then those bronchi are going to split again into tertiary bronchi or segmental bronchi. So we've got a primary here, a secondary here, and then when the secondary splits, it's called tertiary or segmental. And then the segmental bronchi are going to split more and more and more so that you have these passageways for air to the 300 million alveoli that exist in both lungs. When they get very small, they're considered bronchioles, meaning small bronchi. Now there's some tissue changes here to be aware of as well. In the trachea, there's pseudostratified ciliated columnar epithelium. As we move down from the primary to the secondary bronchi, that transition will be into a simple ciliated columnar epithelium. The farther we go down, we'll lose some of the cilia, but we also gain some smooth muscle. So we have now left what's called the conducting zone, whose job is to conduct or move air to this area, which is called the respiratory zone. And the respiratory zone has respiratory bronchioles, terminal bronchioles, and you'll notice that there's a considerable amount of smooth muscle here. Now that smooth muscle you may have seen in action or heard of, it's responsive to chemicals like epinephrine or albuterol in terms of closing airways or opening airways. These bronchioles are then going to carry air into the alveolar sacs and these individual alveoli. So if you look at the picture down here, you'll see that the alveoli each have their own walls, which allow for gas exchange to the pulmonary capillaries, but they're also kind of connected in a honeycomb sort of way. So if this alveolus isn't healthy or is diseased, then air could be shunted to this alveolus or this alveolus. So just because one alveolus isn't healthy doesn't mean that that whole alveolar sac becomes useless. Now, a little anatomical reminder, the blue right here is actually the pulmonary artery or branch of it that's come from the heart. So it's carrying low oxygen blood. Then gas exchange happens here in the pulmonary capillaries where O2 is picked up and CO2 is dropped off to the alveoli. And then the red here is going to be a branch of the pulmonary vein. So that's one of the exceptions, one of the pairs of exceptions to arteries are red, veins are blue. Arteries are well oxygenated, veins are not well oxygenated, or meaning blood in them. So the walls of the alveolus itself are made up of type 1 alveolar cells, which are simple squamous epithelium. They're nice and thin. They allow for rapid diffusion of gases down their concentration gradients. That's a passive process, which is enabled by the fact that it's simple squamous epithelium. The greenish cells that you see here are type 2 alveolar cells who have a very special job. Their job is to produce a lipoprotein called surfactant. And surfactant helps to coat the walls of the alveoli so that when the alveoli come close together as you're breathing out, say, that they don't just stick to each other. It's the technical way to say this, the chemistry way, is that surfactant decreases surface tension within the alveoli, which is really important. One of the biggest problems with preemie babies is that we don't start making surfactant until at least 6 months in utero. So if a baby's born before that, they don't make their own surfactant, which makes breathing really difficult for very small chests and very small muscles. The purple cells that are in here are our old friend macrophages. These are cells that perform endocytosis of debris or chemicals or anything that is antigenic to you, anything that's foreign to you. And as you'll see in my stat a couple of slides earlier, we get rid of about 2 million of these every hour. So the lungs themselves are tissue that helps to organize, house, and protect the bronchi and the alveoli, the bronchi, the bronchioles, and the alveoli. And they're not muscle. They're surrounded by muscle in the walls of the back and the walls of the chest, but they're not muscle themselves. They're mostly elastic tissue and some connective tissue. When you get a chance to feel these in the lab, it's pretty surprising the first time you feel them how pliable they are. They're softer than a kitchen sponge, really. So they are protected by membranes called pleura, and the pleura are serous membranes. So there is the parietal pleura, and this one lines the body wall, and then the visceral pleura, which is a very thin membrane that sits right on the lung tissue itself. Primarily, pleural fluid is made by the parietal pleura, and here's kind of an interesting fact that the turnover rate for this fluid, because you have to constantly recycle it, is about 0.1 to 0.15 milliliters per kilogram of body weight per hour. So the short version of that is there's pretty high turnover of pleural fluid throughout the day, which is a filtrate of these arteries and veins that you'll see here within the intercostal muscles. The space in which pleural fluid sits is called the pleural cavity. And the pleural fluid's job, much like it was with pericardial fluid for the heart, is to help resist friction or the forces of friction, to help keep the outsides of the lungs lubricated and to help keep them protected as well from debris. And here's just a couple of notes on blood supply to the respiratory system. So when we talk about the heart and the cardiovascular system, we talk about pulmonary circulation. So that pulmonary circulation, the job of it is to help us do gas exchange with blood that's come from the heart and goes back to the heart. The lung tissue itself is supplied by bronchial arteries and veins. These are high pressure because they're part of systemic circulation, not pulmonary circulation. They also, the bronchial veins end up dumping their blood into the pulmonary vein. So that means that you always have a little bit of mixing of this low oxygen blood from the bronchial vein into the pulmonary vein. So in theory, a pulse ox, which is a piece of equipment that measures in an infrared manner how much oxygen is attached to hemoglobin, in theory, a pulse ox machine can't give you 100%. Now, they may be calibrated to factor out the bronchial vein blood,